Yes, we see your screen. Thank you. Good morning.
Thank you. Thank you. Thank you. Welcome, all of you. My name is Nancy White, and from the screen you can see who I am and what I am. I'm the education chair for the San Diego County Breastfeeding Coalition, and this is our fourth in a series of 6 webinars. Unfortunately, we can't hold our usual large World Breastfeeding Week seminar, but we're hoping that you're enjoying these webinars, and we hope you enjoyed Dr. Lori Feldman-Winter last Saturday with some excellent information and recommendations on COVID-19. As you know, all of the seminars will be at 10 o'clock on Saturday, and you'll receive a link to the evaluation and the recorded webinar within a few days, and your certificate of attendance will be emailed to you. As you may be aware, World Breastfeeding Week theme for 2020 is Support Breastfeeding for a Healthier Planet. And neither the planet nor its human population appear extremely healthy these days. I want to take just a moment to say a silent thank you to all the scientists and healthcare providers fighting COVID-19 and all of the firemen and emergency responders fighting our California fires right now. Nonetheless, the world must go on, and so must we. Hypoglycemia is one of the most common reasons for infant supplementation in the hospital, and that leads to a shortened duration of exclusive and any breastfeeding and changes to the gut microbiome, which may have lifelong health effects. So that's what we're going to talk about today. As you can see, I'm a neonatologist and a lactation consultant. My BA is from UC Berkeley. My MD and residency in pediatrics was at the University of North Carolina in Chapel Hill. I had a fellowship in neonatology at UC San Diego, also took ECMO there. I've been an IBCLC since 1988, and after 37 years as an attending neonatologist, and over 18 years as medical director of lactation at Sharp-Murray Birch, I retired from clinical practice a year ago in January of 2019. I'm still proud to be a board member of the San Diego County Breastfeeding Coalition, and proud to say that with Mary Sammer, I helped found it in 1994. On a personal note, I'm the mother of a formerly breastfed student of archaeology and mother to 2 large dogs, and I live here on Point Loma. So we are going to start with a poll, just one. The definition of neonatal hypoglycemia is any blood glucose value less than 47, any blood glucose level less than 60, varies with the age after birth and condition of the infant, and always includes symptoms of hypoglycemia. So if you would go ahead and just place your votes, and I'll give you another few seconds to do that, and we'll see what people say. Oh, come on, the rest of you, let's vote. You know how to do that. There you go. Keep going. Okay, I'm going to end the polling now. And I'm going to share the results. Well, some of you have read the pediatric endocrinology recommendations, or one person has, but most of you already know what I'm going to tell you. The definition of neonatal hypoglycemia is not settled. It's not a single number, and it varies traditionally or every time with the age after birth, goes up after birth, and with the condition of the infant. So we're going to start with my computer not moving. Okay, well, this is the first time we've had problems, and it's with me. Let's try this. There we go. So these are the objectives. We're going to recognize the normal pattern of blood glucose in term well newborns. We're going to discuss the various definitions of hypoglycemia, look at indications for appropriate glucose screening. Certainly not every baby needs to be screened. And we're going to describe breastfeeding supportive ways of treating hypoglycemia once it is diagnosed. We're going to recognize the role of dextrose gel, which is relatively new, and try to find ways to write adequate protocols. So normal transition. Well, breastfeeding is natural and normal. It's instinctive for the baby who crawls and finds the breast, but it's not necessarily instinctive for the mother unless you've seen it. You've had a mother who or an aunt or a friend who's breastfeed, you don't really know what normal is. You certainly don't learn it from the formula manufacturers who give you these idealized pictures of breastfeeding. There are always expectations versus reality. We have to talk to mothers in the terms of reality. And who defines successful breastfeeder? Well, it's the breastfeeding. It's the mother herself. It is what she chooses to do. Now, hopefully, as healthcare professionals, we can add some information and answer her questions and target our education as to what research says is best for her baby and for her and her family. But any breastfeeding is better than none. So yes, just getting colostrum or the first few days of breast milk is important in establishing a normal biome. And we also have the difference here in developed countries of breastfeeding versus breast milk feeding. You know, everybody's given a pump as a birth present or so you don't necessarily need a pump, but if you're going back to work, you do. And we have to recognize breastfeeding failures. What is that? It's not the mother's failure, it's the failure of the healthcare system to support her. So we don't ever want to see readmissions. We don't want to see tragedies, babies suffering morbidity and mortality on the altar of breastfeeding. We have to make sure that we're doing our part to help these mothers. So infants know what they want. They certainly do, and this baby certainly does, and mother's response is just priceless. So how do babies transition from fetus to newborn, and what does glucose have to do with it? Well, the normal physiology of transition, infants are very well hydrated. Their urine output exceeds whatever we give them. It's whatever the placenta gave them before they were born. Small colostrum feedings are physiologic. They're appropriate for the size of the baby's stomach, which increases over time. They're sufficient to prevent hypoglycemia in full-term healthy babies. The small volume is easy to manage as the baby learns how to coordinate suck, swallow, and breathing. And we do know that babies suck for comfort as well as nutrition, and their sucking needs are much greater than their need for nutrition initially. How much weight do you lose? Well, that depends whether you're breastfeeding, mixed feeding, or formula feeding. This is actually a picture I took in South Africa of a mom feeding her cubs. She kept rolling over and they kept jumping over and reattaching. But if you're breastfeeding, you lose more weight and it takes you a little bit longer to regain your birth weight. But we have an obesity problem. Could it be that, you know, breastfeeding is normal and formula feeding, which actually doubles the amount on average of the intake of each baby, is one of the causes of our obesity epidemic? Well, remember, the normal is the breastfed baby. They lose a little bit more weight on an average of 6 to 7%, and then they take a little bit longer to regain that weight. During the first day of life, the first 24 hours of life, the average in this study was 15 grams of milk with a standard deviation of 11 grams. You can see in the first hours, the amount of milk was an average of 3.4 mils, which is not very much. So nature is setting us up to do it correctly. And by overfeeding, we're setting us up to have lifelong obesity problems. So why all the turmoil about hypoglycemia if this is all a normal occurrence? Well, it's the most common metabolic problem in the newborn, and approximately 30% of our babies are considered at risk. And we'll go into what is at risk, what is a condition that's at risk in a little bit. But of that 30% that are considered of risk, about 50% develop hypoglycemia by anybody's definition. And we'll go into definitions, which is very difficult. It's the hardest thing about hypoglycemia. It's a readily preventable cause of brain injury in newborns. Although it's rare, it does happen. And there's no universally accepted safe blood glucose concentration. Even recent research shows, following babies out to 4 years, shows that even very high glucoses, anything out of a normal kind of range or a rapidly increasing glucose can be dangerous for babies at risk. So what about glucose? Well, this is how you and I manage our blood glucose. We take in glucose from our diet. We also make it from various substances in our liver. We store it in our liver in the form of glycogen. We break it down to glucose again and put it back into the blood. It's used by muscle and other tissues. It's used a lot by the brain. It also is stored as fat, and it can go out through the kidney into the urine. So there is a balance that your body maintains, and unfortunately, newborns take a little bit of time to reach that balance. So what about the fetus? What does he do or she do? Well, the enzymes to make glucose are present in the fetal liver, but the fetus doesn't produce its own glucose. He relies on maternal glucose levels, and fetal glucose levels are usually 70 to 80% of whatever mother's is. So that if you have a constantly high maternal glucose, as in uncontrolled diabetes, your baby's glucose is going to be high as well. The fetal pancreas can secrete insulin in response to maternal glucose from about 20 weeks gestation on. Glycogen, which is the storage form of glucose in the liver, it begins about 27 weeks gestation, and it's stored in newborns not only in the liver but in the heart muscle and in skeletal muscles as well. The increase in fetal insulin levels inhibits gluconeogenesis, which is the production of glucose from precursors in the fetus. It encourages fat and glycogen storage for their metabolic needs after birth, and it's a primary growth hormone. So insulin, the insulin that the baby sees, that his pancreas produces, is a growth hormone for the fetus, not so much a glucose regulating hormone. After you cut the cord, what happens? Well, the blood glucose drops like a stone in the first few hours after birth. Catecholamines respond to that. Epinephrine, norepinephrine, and dopamine and cortisol are all released by the adrenal gland in response to the stress of labor and delivery and low blood sugar. Falling insulin level promotes the release of glucagon, which stimulates the release of glucose from the liver. And the net result is increased breakdown of fat to release glucose, breakdown of stored glucose in the liver, formation of new glucose from precursors, which leads to increased blood glucose. So there's this counter-regulatory cascade that actually helps the baby respond to this rapid drop in glucose level after birth. And we should know that full-term healthy newborn produces 4 to 6 milligrams per kilogram per minute of glucose, which is twice the amount that you and I can produce. So babies are geared towards making this adaptation, most of them. So these are the glycogenolysis. These are just definitions for you, but alternate energy sources can also be used preferentially by the newborn, much better than you or I can. Ketones from brown fat, which a normal full-term baby has lots of, glycerol from breakdown of fat, and alanine from breakdown of protein. And we also know that the newborn brain is much more pliable than yours or mine. They recover from all sorts of insults much better, but they are also better able to use these alternate fuel sources than you or I. and 50% of the baby's energy in the diet comes from fatty acids. So neonatal hypoglycemia is either a feature of another illness or it's a failure to adapt from the continuous flow of glucose from the placenta and the mother and the umbilical cord to the transient fall of glucose after the cord is cut. And also, it may be in some babies, especially those with inadequate stores or too much insulin, an inability to mobilize that glucose during those times when the baby is not being fed. Now, a full-term healthy baby is rarely fed continuously, but it's intermittent feeding. And so what happens during that time is the counter-regulatory mechanism takes over. Transient hypoglycemia in the newborn is extremely common, and it happens in almost all mammalian species. Most mammalian species are not fed continuously. They are fed intermittently, and their body has to adjust. So this happens the minute the cord is cut in almost every species. In a 1950 study, the mean plasma glucose levels in newborns not fed for 24 hours after birth. Now, I wasn't a doctor in 1950, but they did a study because 24 hours is what apparently doctors at that time used to keep babies NPO to see if they'd make the transition okay. And then they'd feed them sterile water to make sure they didn't have any other GI problems. So babies weren't fed for 24 hours. Well, the mean plasma glucose levels in infants not fed for 24 hours after birth were 57 to 69 milligrams per deciliter, which is perfectly normal. So most babies will make the transition without our help. So we do also know from research that breastfed term infants have lower blood glucose levels than formula-fed babies and higher ketone bodies. And these ketone bodies are higher in the babies with the lowest blood glucose levels. So this suggests that provision of this alternate fuels constitutes a normal adaptive response to the transiently low nutrient intake during the time that breastfeeding is being established. And it has also been suggested that breastfed infants may well tolerate a lower glucose level than formula-fed infants. Now, what about the pathogenesis and the diagnosis of hypoglycemia? Well, how you define hypoglycemia is a big question. Nobody knows what the right number is because it's a different number for every baby. So we have the epidemiologic approach, which takes a whole host of babies, measures their glucose at certain time points, which will show you some of those results. We have the clinical manifestations. Does the baby show any signs of hypoglycemia? And as you know, the signs are very, very nonspecific and could indicate sepsis or something else. There are acute changes in metabolic and endocrine responses and neurologic function. We haven't found any reliable markers right now to date. There's also the long-term neurologic outcome, and we don't want to try our babies with, keep our babies hypoglycemic or low blood sugar just to find out what the outcome is. So epidemiologic approach, what are normal glucose values? Well, it depends. There's really no consistency. Values are different in whole blood versus plasma and serum. The glucose concentration in plasma or serum is 10 to 18% higher than in whole blood. And that's because the whole blood, red blood cells are eating up and using the sugar for energy. There's lots of different varying methodologies in all the different studies. The age of the infant, if you check every baby at 1 hour of age, you're going to get a very different value than if you check them at 4 hours of age or 8 hours of age or 24 hours of age. There's lots of different feeding regimens. Was the baby breastfed, formula fed, mix fed? How long has it been since the last feeding? Was it 24 hours? Was it 4 hours? Was it 2 hours? The number 47 that people keep citing comes from a preterm study in 1988 by Dr. Alan Lucas, who's a wonderful researcher, but his babies were 30 weeks in the NICU, Their mean weight was 1,330 grams, and they had a blood glucose of less than 47 for 5 days or longer, and they initially had a poor neurologic outcome. Well, when they followed these children up, their outcome was much better, was improved. So 47 is not a magic number, and don't let anybody tell you it is. So this is the normal pattern of glucose levels. In Europe and most of the world, they use millimoles per liter, so I have that conversion on the left side of the chart. But everybody's blood sugar, every newborn's blood sugar falls. And the pink line is the mean, the yellow line is the 95th low confidence interval, and which is down as far as 20 in some babies, and the high level is the dark purple line. So it falls and then it comes back up whether or not you are fed. This is a more recent study in 2000 by Hoseth, and again, it shows you a wide range of cord blood glucose, and then it falls dramatically and comes back up. And again, the conversion, this is in millimoles per liter, so the conversion is on the right side of the chart. But you can see it comes back up again. This is the normal function of normal full-term babies. This is even newer. This was published in 2018. However, the numbers are from 1998. Why 1998? Well, because in Arkansas, where this was done, at the University of Arkansas, there were no IV fluids for laboring moms, and infants were not fed immediately. They were NPO for 4 hours, and then their blood sugar was taken. So here is the time. You can see that the LGAN is the extremely low gestational age infant. They drop their blood sugar faster at 60 minutes of life. And actually they did samplings of various babies at various times over the first 4 hours, but they were not put to, very few mothers were breastfeeding. The preterm infant is the green line, which again goes down low and is earlier than the full term and late preterm infants, which are the black lines, and the dotted blue lines here. Their fall in glucose was a little bit later. So obviously the full term and late preterm had more glucose stores and had a more mature counter-regulatory system. This is the latest study, which was published in 2019. Again, you see the glucose concentrations are in a regular curve. And if you look at time, this is gestational age actually. Here's blood glucose level and gestational age. Even the late preterms are a little bit lower. And then as you get to full-term babies, the average glucose level, although there are lots of outliers, is higher. So what do? Significant hypoglycemia is not and can never be defined by a single number that can be applied universally to every individual patient. Rather, it's characterized by a value that is unique to each individual and varies with both their state of physiologic maturity and the influence of pathology. So how do we write a protocol? Well, again, this is workshop, Institute of Child Health and Human Development, back in 2009, said, at present there is neither a rational basis nor sufficient evidence to identify a specific value or range of plasma glucose concentrations that would define hypoglycemia as a pathologic entity. And in 2011, when the AAP published their hypoglycemia guidelines, again, there is no single concentration or range of plasma glucose that is associated with clinical signs. There's no consensus regarding which number of glucose requires therapeutic intervention in an asymptomatic infant. And the generally adopted plasma glucose concentration that defines neonatal hypoglycemia for all infants as less than 47 is without rigorous scientific justification. So 47 is not the number. So Hornblath, instead of saying this is normal and this is abnormal, said, okay, let's have something called operational thresholds. In other words, what is the number at which I'm going to intervene? And the intervention may be simply putting the baby back to breast, or maybe giving IV glucose. And what is the objective? Where do you want to keep the baby to give a little bit of wiggle room in case it falls again? So you can see the levels he chose here. For any intervention, less than 36. For IV glucose, less than 20 to 25. And then keeping the glucose a little bit higher for with some room for error. They also stratified it by age after birth, because as you saw on those graphs, the glucose goes down and then it comes back up again. And so they gave it by age as well. And in this particular study, they looked at a meta-analysis of many of the different studies which measured the numbers for glucose. And they said they recommended low thresholds based on the 5th percentile. And most of these babies were not breastfed. They were published studies that were quite old, but they recommended that 28 was the lowest threshold before you did something. And they suggested that the low threshold for breastfed babies, exclusively breastfed babies, might be even lower. Oh, wait, here's another definition, clinical signs. Look at all these clinical signs. Irritability, lethargy, stupor, apnea, tachypnea, hypothermia, hypotonia. See, by the time you get to seizures, you really don't want to wait that far, but clinical signs should be alleviated with a correction of plasma glucose levels. And that is Whipple's triad. Those of you who have heard of it didn't know what it was. It's a reliable low blood glucose measurement, clinical signs and symptoms consistent with hypoglycemia, and resolution of the clinical signs and symptoms after restoring glucose to normal values. Now, if you wait 24 hours after seizures start, you're not going to have resolution of the clinical signs, but this is immediate. And he was dealing with adults and pancreatic cancer, but this is Whipple's triad. Okay, what are the main causes? Well, the baby on top up here happens to be a full-term baby who weighed 1,300 grams at birth, the infant of a mother with a bad habit, namely cocaine. So the baby is undergrown, doesn't have a whole lot of brown fat, and in his case, he has decreased substrate availability. He has low stores of he has essentially no brown fat at all. This baby happens to be a premature baby at 35 weeks, who is, of course, an infant of a diabetic mother who has seen high blood glucose his entire prenatal life and put out a lot of insulin, which he can't stop on a dime as soon as the glucose from the mother is stopped. So there are lots of other causes as well. And this is a little bit more detailed for your reference. What about acute physiologic changes as a definition? Well, despite looking for EEG changes, Bayer changes, cerebral blood flow, we really don't have a reliable measure of when a baby is truly hypoglycemic. In other words, what is the threshold for neurologic damage? We also know from these studies that neural damage attributed to hypoglycemia is not just inadequate energy storage. It's an accumulation of toxic substances in the brain. And because this takes time, brief periods of hypoglycemia are unlikely to cause neurologic damage. And by brief, we're talking an hour, 2 hours. Long-term neurologic outcome, well, there are lots of studies, and I'm going to show you some if I speed up. We have to figure out how low does it have to be, how long does it have to be low, which infants are most susceptible, and other factors such as sepsis or some other injury are important as well. The immature brain appears to be fairly resistant to hypoglycemia through many mechanisms. In rat studies, we know that death of brain neurons occurs with a glucose less than 18 milligrams per deciliter plus it has to be long enough to induce a flat EEG for greater than 30 minutes. Now that's in rats. We are not going to do this to people. There are a lot of studies, and this is a list of a lot of the studies. I have a couple that are even more recent than this, but this is a meta-analysis, and they found that there was a high risk of bias in many of the studies. And this is, I'm not going to go through it all, but there's a lot of information in this study. So, again, no studies have demonstrated harm from a few hours of asymptomatic hypoglycemia during this normal postnatal period of establishing physiologic glucose homeostasis. That's from the American Academy of Pediatrics. It was written in 2011, and it was reaffirmed in 2015. Little or no evidence exists to indicate that asymptomatic neonatal hypoglycemia at any concentration of plasma glucose in the first days of life results in any adverse sequelae in growth or neurologic development. Again, you have the backing of the AAP here. Well, let's look at neurologic outcomes, those studies that have been done. This was a study that was done and published in the New England Journal of Medicine in 2015. They showed that what they did was take point of care glucose measures, reliable ones with a blood gas machine, but they also inserted a subcutaneous continuous glucose monitor, which measured the glucose every 5 minutes. And they found that 25% of infants with glucose less than 47 in continuous monitoring were not detected with the intermittent monitoring. So just doing a one-time glucose or even a series of glucoses are not going to catch all the babies with hypoglycemia or hyperglycemia either. 25% of those treated for neonatal hypoglycemia had at least 5 hours of low interstitial glucose. And they found at 2 years of age that the glucose level was not predictive of later neurodevelopmental impairment. The lowest blood glucose was not predictive, the number of hypoglycemic episodes were not predictive, and the combined blood and interstitial episodes were not predictive, and they used less than 47. Neurosensory impairment in this study, however, was associated with a blood glucose of greater than 54 milligrams per deciliter. In other words, too high may be as bad as too low. A higher interstitial glucose in the first 12 hours, a steeper rise in interstitial glucose with dextrose treatment. In other words, giving that bolus of 2 grams per kilo makes it rise very quickly. A U-shaped relation was found. Infants with the highest quartile of time outside of the central blood glucose band of 54 to 72 were more likely to have cognitive delay. Then they studied the same babies at 4.5 years, and they found there were some slight differences. The only difference was with visual motor function and executive function at 4.5 years. The highest risk children were exposed to severe, recurrent, or clinically undetected interstitial episodes of hypoglycemia. So there was a difference with the executive functioning and visual motor functioning only for the most severe and persistent episodes at 4.5 years. This is a study by Kaiser. It was done in the University of Arkansas. He was also on the other study in 1998, but not published until, they didn't look at the numbers until 2015. These babies were 23 to 42 weeks gestation, and every infant was screened by the glucose oxidase method, which is a reliable method, which I'll show you. They were matched with other newborns, 1900, and they matched 1395 of their 1943 newborns with 4th grade age 10 achievement test scores, and their definition of transient hypoglycemia: infants with at least one glucose concentration of less than 35, less than 40, or less than 45, followed by a glucose that was greater than what each one of those three numbers. They gathered maternal data, infant data, socioeconomic status data. Their results, that the median glucose was 57 milligrams per deciliter. They found that, I'm sorry, I don't know what, this less than 35 was 6.4% of their population, less than 40 was 10.3%, and less than 45 was 19.3%. And they concluded, after controlling for multiple perinatal factors, early transient hypoglycemia was associated with decreased probability of proficiency on literacy and mathematics fourth grade achievement tests. Okay, so these are 10-year-olds, and you can see here that there are extremely wide variance here. Their standard deviation is wide, but the babies who had, they're showing here that the babies had, who had the lowest glucoses had a little bit lower scores on achievement tests in both mathematics and literacy. However, there are a few problems with this study, and I'm not going to go through all of them, but again, all newborns were tested, not just at-risk newborns. It was retrospective observational data, not prospective data. It was not a randomized controlled trial, certainly. They only recorded the first two values. The glucose readings were done at the discretion of the nurses, not at any specific times. There was only intermittent monitoring. Treatment was not addressed in any of their data. They had no information regarding breastfeeding versus formula or when these babies were first fed. No skin-to-skin info was there. In 1998 in Arkansas, I expect there was probably very little skin-to-skin being done. And they only matched 71%. It's the interesting 74.8% of the mothers had less than a high school education. The hypoglycemic infants were smaller than the ones who were normoglycemic. You can see there 25 to 2,600 grams versus 2,900 grams, and more of them were SGA. We also don't have any information about the childhood history. So there's a lot of problems with this study. The latest study published in the New England Journal of Medicine in 2020 did a study of at-risk newborns, in other words, at risk for hypoglycemia, the SGA babies, the borderline preemies, the infants of diabetic mothers. It was done in the Netherlands in 17 academic hospitals. All the babies were were greater than 35 weeks. They used a treatment threshold of less than 36 in one group and less than 47 in this. It was a randomized multi-center trial, and they found that at 18 months, when they studied all of these babies, that the cognitive scores were essentially identical. And they said the lower glucose threshold of 36 milligrams per deciliter was non-inferior, which means it was no worse than taking a threshold of less than 47, except that if you took 47, you were sticking more babies and treating more babies. So the babies turned out the same, whether or not they used a threshold of 36 or 47 to treat them. No difference in outcomes at 18 months. I assume they're going to present another paper in a couple of years when these babies are older. So, evidence from studies of humans and other animals suggests that cortical damage and long-term sequelae occur after prolonged hypoglycemia sufficiently severe to cause neurologic signs. So it's the symptomatic baby we need to worry about, not the asymptomatic baby with any particular number. How do we prevent and treat hypoglycemia? Well, how do we assess glucose levels? The bedside glucose strips are helpful, they're inexpensive, they're practical, but they're not reliable, especially at lower values, which is what our babies are going to have. They were meant and developed mostly for adults and older children with diabetes. We now have ones that supposedly were developed for babies, but still, they're still not as accurate as the newer point of care devices, the glucose electrode, the glucose oxidation method, which is the HemaQ, and your every blood gas machine can now do basic chemistries, and one of those is glucose. So we have to either, if we're using these bedside glucose testing strips, we need to confirm it, especially the low ones in the laboratory, or we need to use the blood gas machine in the NICU. Continuous interstitial monitoring. You get the results in 5 minutes, the results every 5 minutes, but the valid readings are not really ready for clinical use. It's only for research at this point. Eventually we'll be using it. They are using it for adults and for older children with diabetes. So what do we do to prevent it? We assess the history and the physical exam for risk factors for hypoglycemia. We monitor the highest risk infants. We keep the mothers continuously together because skin-to-skin care, as you all know, improves glucose levels. Early and frequent breastfeeding, nurse within 30 to 60 minutes, very selective glucose screening, confirming plasma glucose is low, demonstrating that symptoms resolve after restoring plasma glucose to normal, and as good healthcare providers, of course, we observe and document everything we do. So we have several trials which show that not only is temperature maintained and crying is reduced, but blood glucose levels are maintained at approximately 10 points higher if you transition the baby skin to skin rather than in an open cot. Again, early skin to skin, the increased blood glucose at 70 to 90 minutes, is 11 milligrams, I misspoke. Selective screening, who do you screen? Well, any symptomatic infant, certainly, and you don't wait for the glucose to come back if you think that symptom is due to hypoglycemia. But certainly SGA, LGA babies, not all of them, but those that do not have good prenatal care, because LGA is a sign of possibly poorly controlled undiagnosed maternal diabetes. Low birth weight, as any asphyxiated baby, any baby who's admitted to the NICU deserves at least a bedside glucose, and certain other syndromes that would indicate a metabolic defect in the baby. So this is the ABM protocol, which I was the first author of. The first version came out in 1999, and we've updated it about every 5 years since then. I have a second draft actually of the 2021. It hasn't been approved yet, but hopefully when I cut it down, it will be. But we want to make sure that in symptomatic infants, we get IV glucose into them right away. You can continue feeding, but if the infant is symptomatic or your plasma glucose is very low, we would recommend that you don't stop to eat your brother like this twin, but you go ahead and give IV glucose. Now you do have all of these slides plus some extras that I've cut out, so you don't have to write anything down. In an asymptomatic infant, this is the challenge. We want to continue breastfeeding every 1 to 2 hours if we can, or feed milk. Now this was in the 2014 protocol from the Academy of Breastfeeding Medicine. We settled on 3 to 5 mils. I think that's a little bit too much. It may take only, if you've got a 3 or 4 kilogram baby, it may take only just breastfeeding and getting a mil or two in, so of expressed breast milk or some substitute nutrition. We want to recheck the blood glucose before the next feeding. Then we want to, in the 2014, actually, we didn't have dextrose gel in there, but we're going to use it now. It's definitely a detailed discussion is in the current version for 2020. If after 2 dextrose gel applications, the glucose remains low, you want to start IV dextrose. But you can continue breastfeeding or orally feeding expressed breast milk. And of course, you want to document everything you do. I'm going to skip this. Except to say that um, study that I showed you before, this is the interstitial glucose going up very, very quickly in babies that are treated. And as they said, too high or too low is bad. So we may want to consider not doing the bolus, or do a smaller bolus or a slower bolus in asymptomatic babies. Uh, um, but that is yet to be confirmed. So when do we scream? We scream. Yeah, I scream. When do we scream? Try to feed at-risk infants immediately, but no later than 30 to 60 minutes of life. Breastfeed or feed express colostrum, donor milk from a milk bank, or human milk substitute if the first two aren't available. Here I do say 1 to 3 mils per kilo is probably enough. Obtain the first point-of-care glucose on all at-risk newborns no sooner than 30 minutes after the first feeding, but no later than 2 hours of life. This goes along with the recommendations of the Canadian Pediatric Society and also the British Pediatric Society. And of course, you want to check any baby you feel it might be symptomatic. Now, what number do we use for treating an asymptomatic at-risk infant? This is where we get into trouble in the United States. The Committee on Fetus and Newborn of the AAP, in that 2011 and reaffirmed in 2015 statement, said one thing, and the Pediatric Endocrine Society, who are dealing with older children, adults, and persistent hyperglycemia, not transient neonatal hypoglycemia, have different views on this. So here is the American Academy of Pediatrics, again reaffirmed in 2015. And here's what they said. Birth to 4 hours of age, you want to, anything less than 25, they suggest IV glucose, and 25 to 40, refeed, and IV glucose if needed, but refeed and let's try again. Now, as the baby gets older and their own compensatory mechanisms kick in, you need to go with a higher level because their blood sugar level is normally higher. So from 4 to 24 hours, they suggest anything less than 35 IV glucose, 35 to 45 refeed, try to refeed, and then use IV glucose if you need to. They had to fight off the endocrinologist who wanted to use 60. So this is the Pediatric Endocrinology Society, and these are very intelligent people who have done a wonderful job, but they're talking about persistent hypoglycemia. Note the title of their paper, persistent hypoglycemia in neonates, and there are some neonates who do have persistent hypoglycemia, infants and children. So the Pediatric Endocrine Society also wrote a paper about transitional neonatal hypoglycemia. And they do say, they give a definition, which is the same as the AAP definition, but they say that this transitional neonatal hypoglycemia is very similar to the low ketones, which doesn't go along with previous research, but low ketones, hyperinsulinemic status, and they're saying that it mimics known genetic forms of congenital hyperinsulinism. So, and based on the fact that if you happen to be diabetic and your blood glucose gets down to 50, you start to get central nervous system signs, brain signs. They said it should certainly never go below 50 because that's when your brain starts to sense hypoglycemia. So I'm gonna go, okay. So we do know it falls. Why do the blood glucose concentrations fall? Well, you're cutting off a continuous source of glucose, but also it may be that newborns and human newborns, as well as other mammal newborns, need an impetus to start their counter-regulatory hormones and enzymes, and it enhances oxidative fat metabolism. The Pediatric Endocrinology Society also says they use means as their blood glucose cutoffs and not the lower ranges like the American Academy of Pediatrics. So where are we now? So here are the current recommendations. The AAP, you can see from the 2011-2015 study, and the Pediatric Endocrinology Society uses 50, and then after 48 hours, 60. And of course, any symptomatic infant needs IV glucose immediately. So we're trying to balance the two, not do too much harm, do any harm, and yet still not do harm by over-treating and over-sticking so many babies. Okay, and when is the baby ready for discharge? The AAP says at least 3 feed-fast periods with a normal glucose, and that would be 50 to 60, and then the Pediatric Endocrinology Society wants a 6 to 8 hour fast with a glucose of greater than 60 before discharge, both of which I think are very reasonable. What about dextrose gel? And I'm running out of time, as usual. There are lots of studies, and you can look at all of these, but dextrose gel reduced the frequency in this study of treatment failure, which was needing IV glucose or admission to the NICU, less NICU admits, better breastfeeding at 2 weeks compared to placebo. This was a study, a randomized controlled trial using dextrose gel with outcome at 2 years. No difference in the neurosensory impairment or the processing difficulty between those who received dextrose gel or placebo. The placebo had no glucose in it. So this was a true randomized controlled trial. Overall, 36% in this study, however, had neurosensory impairment, although the majority were mildly impaired. I think they had a very sensitive test for neuroimpairment. Oral dextrose gel reduces the need for intravenous dextrose therapy. So dextrose gel with feeds increased the blood glucose level in 74% of their babies. Feeds only increased the blood level in 58%. Transfer to the NICU for IV therapy went from 35 per thousand to 25 per thousand live births, which was significant. And exclusive breastfeeding in this study went from 19 to 28%. And this was at Children's Hospital in Buffalo, New York. Again, in this particular study, done in 2015 or published in 2015, they had a significant increase in breastfeeding and a decrease in supplementation, and more babies were breastfeeding at 3 months if they used the glucose gel. So this is basic steps for glucose algorithm. I'm going to let you read that for yourself. It's a very nice article in Nursing for Women's Health. Again, you can see here when this particular study decreased, started using glucose gel, their infants admitted to the NICU fell significantly. And this is the Cochrane database of systematic reviews, the kind of be-all, end-all for treatment. This is an evaluation of the randomized controlled trials, and the Cochrane database reviewed all of the studies available at that time and said in 2016 that oral dextrose gel should be considered first-line treatment for infants with neonatal hypoglycemia. So you have the entire Cochrane database behind you, not just the AAP. Okay, our conclusions. So how aggressively should we diagnose and treat hypoglycemia? Well, there are certain benefits. Early treatment of severe hypoglycemia disorders is certainly a positive. We want to potentially prevent symptomatic hypoglycemia. We want to prevent neurologic injury whenever we can. We want to correct any abnormalities. If this is an SGA baby with a very delayed response and poor fat stores and a delayed normal compensatory response, we want to correct that abnormality, and of course there's less legal risk. On the other hand, If you treat aggressively and you test aggressively, you're separating from the mother, putting the baby in the NICU. The hospital stay is longer and the cost is much higher. You're decreasing breastfeeding. You're using intravenous catheters and IV fluids, which in themselves have risks. You may be giving medication like glucagon to increase your blood glucose, which has side effects, and you have the risk, which that study showed, of hyperglycemia, which may indeed itself be a risk. So we have to weigh the benefits and the risks of how aggressive we are at diagnosing and treating hypoglycemia. We also have to remember that anything we do to the baby, we do to the family. So we want to make sure that the mother is supported. Our conclusions in 2014 were that early and exclusive breastfeeding meets the nutritional and metabolic needs of healthy term infants. Routine supplementation is certainly unnecessary and is harmful in terms of the microbiome and long-term health and lack of exclusive breastfeeding. We want to initiate breastfeeding immediately. We want to promote skin-to-skin contact. We want frequent feeds if we can. We all know that the first night, the baby may fall asleep, but the second night can be a doozy. So put that baby to breast as soon as the baby stirs. Glucose screening only in at-risk and symptomatic infants. Routine screening, as they used to do in Arkansas in 1998, is not appropriate, and no one recommends that. We want to continue monitoring until the preprandial levels are consistently normal by whatever standard you're using. And bedside glucoses, the normal glucose strips, should be confirmed in a laboratory or on your blood gas machine. Mama's anxiety is something she always feels that she's the reason this baby is needing special care for hypoglycemia. So we have to help her overcome her feelings of inadequacy, help her maintain her milk supply, establish her milk supply and maintain it, and keep the baby at the breast and keep breastfeeding going as much as we possibly can, along with skin-to-skin care. There are various guidelines available. This is a wonderful study. It's a very complicated looking guideline from Sweden, but it is in English, and it is excellent. The Canadian Pediatric Society guideline is also excellent. This is a wonderful resource, and it's easily available. It's free. And also the Journal of Human Lactation published the British Framework for Perinatal Medicine Framework for Practice, and it is available for free as well. Jane Hawden did a wonderful summary of it. So this is, you see the Journal of Human Lactation in 2019. This also has algorithms for you. So we also know this study was just published this past month ahead of print, and it shows you that in this was a quality improvement study in Minnesota, and it showed that the rate of breastfeeding within 1 hour of birth in asymptomatic infants at risk for hypoglycemia went dramatically up after they had the HGA. This was their first protocol. The HGA2 was their second, which used glucose gel, and you see it continued to go up. The rate of dextrose gel use also went up during the first period. And look at their IV glucose rate. When they added the algorithm in this time period, their IV glucose rate went down. When they added the glucose gel, it went down even further. Their NICU admission rate was not quite as dramatic, but it went down as well. Their breastfeeding rates went up, both with their hypoglycemia algorithm alone and then with glucose gel. And their average length of stay went up a little bit with their algorithm, but then went down significantly back down with the glucose gel. So quality improvement, you don't have to do a research study. You can do a quality improvement study and show this difference. So conclusions, healthy full-term infants are programmed to make the transition from fetus to newborn through the normal breastfeeding process. Routine monitoring is not necessary. Hypoglycemia can be minimized by early frequent feeding. Symptomatic hypoglycemic infant is the one of concern for long-term outcome problems, and they need IV glucose, not forced feedings. Mothers of hypoglycemic infants need support. Supplementation with heat-treated donor human milks meets the Joint Commission criteria for exclusive breast milk feeding, and glucose dextrose gel is inexpensive, effective, and should be added to all hypoglycemia protocols. So breast milk is the choice for a new generation, and I thank you very much for your patience. If there are any questions, I'd be happy to have them. I don't see any. I must have overwhelmed you. Are there any questions for me? Or any comments? I'll take comments, questions, or anything that you'd like.
Thank you, Nancy. That was really thorough. I really enjoyed that.
Oh, Maricela, you're biased. Well, thank you all for attending. Oh, Jackie raised her hand. Okay, can you, let's see if we can, how do we get the hand raising here?
We do have one question. It says,
can we
actually,
unmute her? We need to unmute.
Well, I can read it too. It says, thank you, Nancy. A very interesting webinar.
Okay, thank you, Carolina.
Yeah, thank you.
But there was a question, there was somebody raised their hand, and I'm not sure how to do that. I'm not sure.
Let's see, I'm not seeing a raised hand. Jackie, let's see if Jackie needs this question.
I am so sorry. I thought I unmuted it for the next webinar. Well, if you have any additional questions for me, please send them on, and I'll be happy to answer them. You'll receive your brief evaluation by email and certificate as well. And we'll hope to host you again next Saturday when Mary Grant, Jara Foster, and Nikki Helms will be speaking to us about perinatal healthcare equity. And I hope you all keep well. And again, think about our healthcare yourself and other healthcare providers, as well as the first responders and firefighters in Northern California. My nephew and my brother are among that group. So we'll see you all next week. Thanks so much.